So the gram-negative bacteria have this pink color under the microscopy. They could be divided into four types based on their shape. They could be diplococci like this one in two pieces together, and then the coccobacilli, and there's the curved rods and bacilli, of course. So the diplococci, they're all aerobic, but based on their ability to ferment maltose, are classified into maltose fermenting like Neisseria meningitis, or unable to maltose ferment, that is Neisseria gonorrhea and Moraxella. So for Coccobacilli, nothing is specific over here, but it will mention the specific stuff by time, just like Haemophilus influenza and Bordetella pertussis. Then there's the bacilli, based on their lactose fermentation ability, then they could be positive, which means they can ferment lactose. If it's fast, then they could be like E. coli, Klebsiella, and Enterobacter, while if it's slow, then it's these two. For the lactose fermentation, if it does not exist, if this bacteria bacillus is unable to ferment lactose, then we're going to check its oxidase now, the oxidase enzyme. So it could be either positive or negative. If it's positive, which means has an oxidase enzyme, then it should be Pseudomonas, or that other one that is Burkholderia. And then if does not contain the oxidase enzyme, then it's going to produce, it's going to be, we're going to check its ability to produce H2S on the TSI agar, and it could be positive, which means it will produce the the H2S. Then it's like it could be Salmonella or Proteus. While if it's negative, which means it does not produce H2S, then it could be Shigella or Yersinia. So the very first thing that we're going to start with are the Neisseria subtypes. Generally speaking, the Neisseria, as we said, a gram-negative diplococci. It metabolizes glucose and it produces immunoglobulin A protease, which breaks down the immunoglobulin A within the body. So it just a virulence factor that can threaten the body's ability to defend. Contains lipooligosaccharides, LOS, with strong endotoxin activity. So these LOS that are contained within these bacteria have a very high or strong endotoxin activity, which we know um, going to be considered a main huge issue in bacterial infection. So the Neisseria gonorrhea is often intracellular, and it's contained within the neutrophils. The meningococci, this is just summarize it better. So meningococci is able to maltose ferment and also use the glucose, like it could work on glucose as well, while the gonococci only work on glucose. So for the gonococci, they do not have a polysaccharide capsule, so they don't have capsule like that prevents phagocytosis, while meningococci they do have polysaccharide capsule preventing the phagocytosis. The gonococci does not have maltose acid detection because it does not ferment maltose in the first place, so there is no maltose acid detection, while the meningococci they do ferment maltose. So we can see there is a maltose acid if we detect it. Then the gonococci, they do not have vaccine due to antigenic variation of pilus protein. So basically, in gonococci, they do have this pilus thing. It's their capability of attaching to the walls and everything. So these pilus have a unique capability of changing their type uh, based on conditions and by time, which means we cannot create a vaccine that cover all of these antigens. So these pilots have antigenic variations preventing us from creating these vaccines. And also the Neisseria meningococci, they do have vaccines for all subtypes, and there is this type B vaccine that is only given for at-risk patients, not all patients, only at-risk patients. The gonococci are sexually or perinatally transmitted, so it could a mother could give it to her baby during delivery, for example, while the meningococci are transmitted by respiratory and oral secretions. It's more common among individuals in close quarters like army barracks or college dorms. So in the army, college students, that would something something we may see in a case scenario. For the gonococci, it causes gonorrhea, septic arthritis, neonatal conjunctivitis, but it starts really early, like within the first 2 to 5 days of the baby's life. Um, so it's a very fast onset conjunctivitis, and that's to differentiate it from other species. A female, because sexually transmitted, a female could develop pelvic inflammatory disease, and if this pelvic inflammatory disease is not contained or not treated very well, it could develop into the Fitz Hugh Curtis syndrome. It is basically this infection is going to spread into the peritoneum, and then it may produce adhesions as liver adhesions, for example. So that's the Fitz Curtis syndrome. While the meningococci, they cause meningococcemia, so there is a spread in the blood with petechial hemorrhages like petechial rash, a red rash on the skin, and also a possibility of gangrene of the toes, as we see here in this image. It could also develop into meningitis, and then Warhouse Fredrickson syndrome, acute hemorrhage adrenal insufficiency. So basically, because there is an interstitial fluid leakage, there is going to be hypovolemia, and a reaction to that is going to be vasoconstriction, but then all of that vasoconstriction is going to end up being really bad for the patient, and the patient will develop adrenal insufficiency because of uh, death or acute hemorrhage within the adrenal gland. The gonococci are diagnosed by NATs, the nucleic acid amplification test, while the meningococci are diagnosed via culture-based test or the polymerase chain reaction. For the gonococci, because sexually transmitted, so condoms reduce the sexual transmission, and the erythromycin eye ointments can prevent the neonatal blindness, because we said that the baby may develop blindness within, or conjunctivitis actually, within 2 to 5 days after birth. While the meningococci, the treatment is rifampicin, ciprofloxacin, or ceftriaxone. Uh, and of course, we need prophylaxis for patients who are in close contact, because it's aerosol uh, transmission. So for the treatment, the gonococci are going to be treated by single dose IM ceftriaxone. If chlamydial co-infection not excluded by molecular testing, then we add doxycycline. Um, so basically, we check this patient for chlamydial co-infection, because that is something that happens every once in a while. So if we cannot exclude that co-infection of a chlamydia, then we can add doxycycline. While the treatment for meningococci, then it's triaxone or penicillin G. Okay. That's for Neisseria types. Now for the Haemophilus influenza, it is small gram-negative coxobacillary rods. They have aerosol transmission, non-typeable, or well, basically we can consider it as there is one that has type B, that has a capsular type B, and this one does have a vaccine for it, while the other one that is non-typeable or unencapsulated, so it does not have a capsule. This one that does not have a capsule is the most common cause for mucosal infections like otitis media, conjunctivitis, and bronchitis, in addition to invasive infections. So mucosal infections and invasive infections. So the vaccine, because they don't have vaccine, they're non-typeable or unencapsulated, we did does not have vaccine yet, while the type B does have a vaccine. So anyway, the Haemophilus influenza produces immunoglobulin A protease, which destructs the immunoglobulin A within the body. It cultures on chocolate agar, but this chocolate agar needs to have two factors in order for the Haemophilus influenza to be, you know, uh, visualized and everything. So the first factor is type 5, that is the NAD positive, while the type 10 or the factor 10, that is hematin, and they're both required to be there on the chocolate agar for the growth of the Haemophilus influenza. Can also be grown with Staph aureus. We can add it to Staph aureus because the Staph aureus has the ability to hemolyze RBC, so it can do the RBC hemolysis, and that would produce the factor 5. And factor 5 is one of the things that we need to add to the chocolate agar. So we can culture Haemophilus influenza in addition to the Staph aureus in order to benefit from the factor 5 of the Staph aureus. The Haemophilus causes epiglottitis, and the endoscopic appearance looks like this. So it's huge, and then the inlet is too small. It can be cherry reds in children, and thumb sign on lateral neck uh, on X-ray. So it just looks like a thumb over here. Patient also could have meningitis, otitis media, and pneumonia. The vaccine for Haemophilus influenza, so as we said, it has the type B capsular polysaccharides. It's the one that we have a vaccine for, conjugated to diphtheria toxoid. So this Haemophilus influenza type B vaccine is associated or conjugated to the diphtheria toxoid or other protein. It's given for the patient, the baby or the child from 2 months to 18 months old. Does not cause the flu. So this influenza does not have the ability to cause the flu symptoms, while the influenza virus does have that ability. The treatment for Haemophilus influenza is amoxicillin plus minus clovolanate for mucosal infection, while the ceftriaxone is for meningitis. Rifampicin prophylaxis for close contact. So because it's aerosol transmission, then we need to be careful. If someone is in close contact to the patient, we need to use rifampicin to prevent the infection. While the other bacteria is Burkholderia cepacia complex. Wow. It's aerobic, that's first, catalase positive, so it does have the catalase enzyme. It's gram-negative rod, okay. It causes pneumonia and can be transmitted between patients with cystic fibrosis. So let's say it's kind of nosocomial, because where does cystic fibrosis patient meet? So basically, because it's as well between two patients of cystic fibrosis and could be considered nosocomial, then it's multi-drug resistance. It has a multi-drug resistance. So if there is a patient that needs a lung transplantation for any reason, like whatever the problem was, and they need lung transplantation, so we check these patients and we check that patient and see that he has this infection, then we don't go with the lung transplantation anymore, because this infection is associated with poor outcomes. So the patient won't benefit from the lung transplantation.